Beth is a patient of mine, and she is 64 years old. Actually, the prevalence for patients with chronic spontaneous urticaria, more females than males have chronic spontaneous urticaria, but both are very confused and they're very upset. A, they're having intense pruritus, and B, they don't know why this is happening to them. When we diagnose chronic spontaneous urticaria, they have to have the urticaria, which is happening for at least 6 weeks period of time. If it is not 6 weeks period of time, just a couple weeks, it's just episodic. But to have CSU, it has to be 6 weeks period of time. It can not only develop the urticaria, not only involve the urticaria, but also those patients, sometimes they can have the angioedema that go along with it. Patients usually are between the ages of 20 and 40. This patient is 64 years old. She's a 64-year-old female, and she is being seen because this rash is non-resolving. She's being referred from her PCP. She has a history of arthritis and the rash. That is the reason why she's on meloxicam, 15 milligrams PO Q day. She also has been prescribed from the PCP triamcinolone 0.1% cream to the affected areas twice a day, and she's taking hydroxyzine 10 milligram tab 3 times a day. Her allergies, she has no known drug allergies at all. She has no known environmental allergies or food allergies. She has a surgical history of having a tubal ligation. Her weight is 190 pounds and she's 64 inches tall. So HPI, she's complaining of a rash, which is warm to the touch, it raised and it's itching. Her itch, when I asked her what her itch is, she said it's more than a 10 when I asked her on a scale of a 10. She's also exhausted. She's been up for quite a few weeks in a row because she can't sleep at night because of the constant itching that is going on. It occurs spontaneously at least 2 to 4 times a week for the first 4 weeks, but now she's having daily spontaneous occurrence. The rash is absolutely worse at night, and she states she can't sleep. And like I noted, she looks absolutely exhausted. She's frustrated. She's on the verge of tears. Her severity is severe. Her duration, she's had it for 7 to 8 weeks with sudden onset, usually in the evening. Then it goes and it persists all night long on to the next day. Usually within 24 hours, it starts to get a little bit lighter. The itch starts to decrease, then it just starts up again. Her pertinent negatives are she's had no blisters, no coughs, no sore throat, no fever, no diarrhea. She also has no history of cancer. Her pertinent details, there's nobody else in the household that has a similar itch that she does. She has no family history of urticaria, no new medications, no new personal care products, no infections or no food triggers. She's wearing pants with elastic and is wearing a bra. And she states that this makes it much worse. Just the feel of that constriction, that tightness around her body aggravates it more. No personal history of thyroid disease. Other subjective data, patrons referred by her PCP after the patient continued to worsen, and she's not responded to topical steroids, nor has she responded to antihistamines or systemic steroids. She was giving prednisone, 60 milligrams with a taper. Other systemic etiologies that include malignancy have been excluded. This is Beth. And as you can see, she has a large burden of those hives or CSU throughout her trunk area. They are involving her back throughout. You can see that they're red, they're pink, they're raised, also under the axilla area, her breast area, her arms, her buttock. She's really miserable. She has been itching nonstop and she can't sleep at night. And these are the areas that are on the front underneath. So her diagnosis or the impression would be chronic spontaneous urticaria, which is L50.1. And she also has an associated diagnosis, which is pruritus. So our plan in counseling, discuss her diagnosis with her, which of course she doesn't understand. Why is this happening to me now? What can I do to change this? What can we do? I can't go on like this. She's very upset. Talk about fragrance-free, dye-free products just to eliminate any other type of triggers or allergens, to wear loose-fitting clothing, especially cotton-type clothing. The antihistamines, H1 second generation histamines, leukotriene inhibitor, and H1 second generation at HS due to the sedating effects. H2 blocker was added, a possible glycocorticosteroid, a possible systemic injection therapy, which we talked about at the first meeting because of the fact that she wasn't responding to histamines before that. However, she wasn't also given all the other types of histamines that block at different areas. And also we discussed to call 911 if she has any throat tightening or difficulty breathing, any drooling, nauseousness or vomiting, and to stop her meloxicam. NSAIDs are a medication also that can contribute to urticaria. So therefore, just wanted to go ahead and rule that out at that time. She could take some Tylenol arthritis, but I wanted her to stop her meloxicam. In regards to medications, I prescribed for her fexofenadine 180 milligrams twice a day. The Tegament or the cimetidine, 400 milligrams twice a day. And I added montelukast or the leukotriene inhibitor, 10 milligrams PO at HS. Increased her hydroxyzine to 25 to 50 milligrams at HS. She was having no effect with the 10 milligram tablet. 10 milligram tablet of hydroxyzine is a 30-pound child dose. However, hydroxyzine is one of those medications, because it is a first generation, it can make adults very sleepy, especially with 25 milligram dosing. So I often do prescribe a 10 milligram dosing. However, if patients, such as in her case, with urticaria and all the histamine release in that, I had to increase it to the adult dose, which is 25 to 50 milligrams at HS. Also, to try to give her a little bit of relief. She was absolutely miserable and beside herself. I did give her 1 IM Kenalog injection of 40 milligrams Kenalog. Follow-up, despite current therapy, she's miserable. And her follow-up was not long. Her follow-up was 7 days later. I do not believe in letting patients go ahead and suffer. However, this has to be documented that we have done everything we possibly can for this patient. She's experiencing CSU every single day now, and this has to be documented. She has to have those scripts filled in order for me to prescribe for her injectable therapy. So in her pruritus is still severe. She's miserable. She continues to flare with her CSU. So patient really, she wanted to refer to an allergist. She really felt that. And she needed to see an allergist. So I referred her right away to an allergist. I have an allergist that's right across from us. And the allergist got her right in. And she just said to increase the fexofenadine to 360 milligrams in the morning and the PM. Also recommended what I had recommended to the patient, to use the omalizumab. And that is what we did. So the international guidelines in US practice recommends increasing the dose of antihistamines up to 4-fold. So that's quite a bit. If you were not suffering from CSU, you would really feel very sedated by these medications. Unfortunately, due to all the increased IgE, as well as the histamine release that's being released, these patients, that doesn't even affect them whatsoever. So the prescription for her omalizumab was sent, and it was set at the 300 milligram dosing sub-Q times 1 now and every 4 weeks. Also, I prescribed an EpiPen for her. The EpiPen was sent to the pharmacy for her, and it's needed for anaphylaxis, potential anaphylaxis, and continued the increased dose of fexofenadine, and no change in the other dosing of her medication with hydroxyzine or the cimetidine. So follow-up after every Q4 week injections of omalizumab, she cleared at the 5th dose. Now, if you're thinking about this, you're thinking, but it took 5 months, right? Yes, it did. But what happens is that you're evaluating your patient as she goes along. And that's the one thing. Some patients do respond quicker than other patients. I have been working with this medication since it was FDA approved. The longest patient that I've had that went ahead and responded was at month 6. Each month they are improving a little bit more and a little bit more and a little bit more. When I say cleared after 5th dose, I mean from that dose that last dose until I saw her again, she had nothing. She was absolutely clear. She had no itching. She had no hives, no urticaria whatsoever. She was 100% that it was like she just did not have this disease at all. So you need to also encourage patients to continue on, then back up on their oral medication to FDA approved dosing as you go along. There's no indication also to talk about when you're going to stop this medication. So if you go ahead and you reach out to your MSL, they do from Novartis, they do have clinical information, and that's what I follow. And so I slowly, when those patients clear, then I go ahead and start, instead of 4 weeks, we go to 5 weeks. If they're clear from 5 weeks, we go to 6 weeks. I go ahead and back them off therapy, and I don't change. I usually stay at that same dose and back them off therapy. But her quality of life is vastly improved, and this patient was able to get off medication after a period of time.